Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians. Practice medicine the way you've always wanted. Data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel at VillageMD. Such a pleasure to be joined today by Andrea Osborne. She's our Senior Vice President of Delegated Services. Andrea, welcome.
Thank you. It's a pleasure to be here.
We're so happy to have you that we put a crown on your avatar.
It's only because I earned that crown only because of the amazing people I get to work with every day.
Well, honestly, you're such an expert, especially with some of these issues like we're talking about today. And you brought this to my attention, this whole world and for our listeners, what we're talking about today is the world of prior authorization for ambulance transportation. And there's quite the background and history here that with your help, Andrea, I've sort of come to understand. So I think it would be good for us to start there.
Yeah, there's new rules regarding prior authorizations for patients who need routine transportation through an ambulance service. And while CMS is focused on fraud and abuse, I also want to take time today to talk about what's the impact on our patients and is there any downstream events?
That's right. Yeah. So just to get everybody up to speed, the first thing to know is that non-emergency transportation, ambulance transportation is covered by Medicare, but very rarely, and you have to be really, really sick. The word is bed confined, but people don't realize like bed confined is like legit, it is very, very serious. And even if you're not bed confined, there are some situations where you might qualify, but the vast majority of people will not qualify. Is that the way you think about it?
Yeah, that's exactly it. If getting out of bed should be very burdensome or almost impossible in order to be really bed bound.
Yeah. So what we've come to understand then, CMS believes, and they've got some evidence from some reports they've done, that there's vast fraud. Like the most recent report was, I think, $24 million in 6 months of payments that don't meet those requirements, and maybe 30 million more that also were sketch. And not only is it vastly paid when it doesn't meet the requirements, but the payments were growing exponentially. And so sometime back, CMS, they just put a moratorium on new providers in some of our counties, some of the counties, villages across the country. So we've been in kind of this state while they're trying to sort out what's going on.
Yeah, so two thoughts here. One, it's really interesting. If you go to the OIG website and you type in ambulance in the search bar, it pulls up just a litany of cases in the past 2 years where they found fraud. So, that obviously is very concerning. The other thing that concerns me is while a few of these places have moratoriums, what I'm hearing from a lot of our clinical staff is as people try to make appointments, there aren't enough ambulance services available. And so that really starts to concern me for the care of our patients.
Well, and that's one of the reasons that CMS gives for this change, because they feel like these non-emergency and especially the repetitive, which we're going to talk about, are soaking up needed transportation that's needed for emergencies as well. So it is a complicated problem. But the driver of the change here is high cost and high fraud is the feeling. So like so many things, CMS took this to their innovation center and they did a study. And this is interesting, but the thing to know is they did them in 2 phases. They started with states that have really high usage, and then they moved into states that had usage consistent with the national average, and just implementing this prior auth. So there's no change in the coverage, the same coverage, and there's no new paperwork or anything for patients or doctors. They really stress that, but it's a prior auth, and it was very, very significant savings, 72% decrease in the area of these repetitive transports, especially where I think, Andrea, my read of this is it's mostly like ESRD and wound care patients who really need to get the care.
Yeah, that's right. A lot of the routine transport is going to be our patients on dialysis or our wound care treatment or our wound care patients. But what I'm wondering when I see this decrease, so we saw the cost of ambulance go down. Was there a cost of increase in ED utilization or inpatient utilization as a result?
I mean, they said in their study that they checked for that, and that they looked at total cost as well. And they didn't see, the study says, now I'm just, telling you what it says, that they didn't see any pop-up of ED usage or fatality or a change in quality. And that's a little bit, I think what's behind this is, none of us believe that Medicare, in Medicare fraud for sure. But I think one of the things that's missing for me in learning about this is care that people need. I think they're getting the ride, because they need it. I mean, just without knowing more, that's what I'm thinking about. And so it's like I'm wondering, and we're going to talk a little bit about what do they do instead. Now, maybe part of it is, Andrea, as you said, there's just this is like the Wild West, and there's just vast, terrible abuse. Maybe that's really what the issue is. I don't know. I don't know what this decrease represents.
Yeah, I agree. I think it'll be interesting to start to see how this starts to impact total cost of care, and starting to read further into some of their investigations to know, is it just a blatant misuse, um, as well? Because you're right, we never want to tolerate fraud. That's not acceptable. We also want to make sure patients get the care they need, and so
Right,
kind of
right.
seeing where this plays out will be very interesting.
I mean, I guess when you look at the coverage rule, a typical ESRD or wound care patient probably doesn't qualify for a covered ambulance unless they're bedbound, which is probably rare.
That's right. It is rare. It's not going to be for a lot of our patients. But I think, ambulance was routine. There were plenty
Yeah,
of them in a lot of states. And so this was maybe sometimes an easier service to find, and a
yeah,
consistent service is my thought behind it for
yeah, I
patients.
agree. Yeah. So just to take a second to say, now they did this pilot, wildly successful. I think it said something like $1 billion savings just in the pilot. So it was major. And so now we're going to see this new rule come into effect. We're going to talk about how it rolls in. It's not just like turns on, it's a rolling effective date. But basically, Andrew, why don't you just tell us a little bit about what the rule does, and maybe a little bit about what it means to be bed confined, just in terms of the definition?
Yeah, so as it's phased in through states, and we'll take a minute and look at those states, it requires that you have prior authorization for patients. And that prior authorization can actually be done in some groups. So it doesn't have to be done each day. For our dialysis patients that go 3 days a week, they can actually do some of it in a group. Um, and the rules, like you said, the rules aren't changing. You just have to have prior authorization, and it has to be documented and signed off by a doctor, which it did before. That bedbound status had to be signed off by a doctor prior. And when we think about someone who's confined to a bed, it's going to mean that they're unable to get up from that bed without assistance, unable to ambulate, and unable to sit in a chair. And so we think about patients, and it could be due to a medical condition. We talked about wound care. We see so many wounds on patients on their coccyx, and sitting up in a wheelchair just wouldn't be good for the wound. It's really going to deteriorate that healing. And so for those patients, being able to stay in a supine position is going to be very important.
So physicians have to certify it, and that's not a change. This is just existing law. The change is really, the burden is on the ambulance providers. In order to get paid, they have to get prior approval. Have you heard at all about how that's going? Is that quick? Is that taking a while? I mean,
It's
prior
taking a
approval
while.
always sounds good, but it's a big, big burden usually.
Yeah, and so if you go to the next slide, this is where I start to get concerned, because so far we only have 2 areas that have gone live, and we're already hearing from ambulance companies when our clinical staff reaches out to get things set up that it is taking a while to get a return. And so if they've already gone live with 2 and it's taking, a few days, there's a lot of concern about how are we going to help patients get to the services they need.
Yep, yep. So Andrea, why don't you just describe sort of how this effective date rolls through the country?
So they're rolling it out in 5 phases. That first phase started on December 1st, and the last phase starts no earlier than August 1st. So about every 2 months, they add in another group of states.
It doesn't, when you look at the grouping, it doesn't make a lot of sense. Like, it's not like north, south, east, west, it's not, it's kind of all over. I mean, to be honest.
It is spread out. I'm not sure how they came up with this pattern, other than maybe there's similar usage for ambulance service as they
Yeah.
group states together. But it really is kind of a interesting geography that they picked out to roll out these 5 different start
So
dates.
for our listeners, if you're not watching along on our video, you can see the rollout on CMS website. There's a map, and you can see the rollout dates on there. But just know that, wherever you are by August 1st, it's you. That's an important thing to know. So Andrea, let's take a minute and say, like, what, so these patients, let's be real, many of them should not have been getting ambulance transportation before, but maybe they were, and now it's going to be harder. So what should they do? And I took a look at the Medicare website, which, let's, no offense to CMS if you're listening, we have a lot of admiration for CMS, but these aren't great options like this Medicaid. What it said on the website is you might get transportation services under Medicaid PACE, which I think, Andrea, is very limited, right?
Yeah, the PACE program, while it's a phenomenal program, is a program that's not available in many areas. So there's a limited number of PACE programs.
Yeah. The other thing Medicare directs people to do is contact this elder care or their state elder care program. And like, I think it's different in different states, but these are not like deep wells of resources typically that are like, it's not like there's like a bunch of cars sitting there just hoping you're going to need a ride. It's not, there's really not, I mean, this is an option, but it's not a really valid, good option in a lot of cases.
It's not, it does vary a lot by state. And even with state, you'll find variations as to the services provided and how quickly they can respond. Unfortunately, as we think about other options for our patients, family and neighbors are always going to be the best resource, the most reliable. I know that's not available for everyone. So as we look at other areas, if you have a Medicaid benefit, and so many people qualify for Medicaid and they don't realize that, and that's probably a podcast for another day, but so many people could use Medicaid and the transportation services provided within them. And although those two have to be scheduled a little bit out for our patients, typically who, like those who are on dialysis, they know what days they go. They go every Monday, Wednesday, Friday, or every Tuesday, Thursday, Saturday, and it's very routine. The other thing I think, we really need to help our patients look at is it possible to get the treatment in the home? So many things are being moved out of an institutional setting into the
So
home, which is
true, so
wonderful.
true. And it's so much better in so many ways, not even convenience, but even safety, I hate to say.
Yeah, I love the convenience. You think about dialysis and a patient having to drive both ways and sit in a chair for 3 hours a day. I mean, that is a lot of their life. And so to be able to get that treatment at home in a time frame that works for them would be wonderful. And so many treatments are available for home. We see a lot of home health companies who now have certified wound nurses who are coming into the home almost on a daily basis to do wound care treatment. There are some more commercial offerings such as Uber Health, has transportation services now. That's not going to be obviously very helpful as we get to rural areas, but
Right, and the cost, might be, I don't know what the cost is. Uber, if your general counsel is listening, I think you guys should really make sure that's affordable for people, because these are people who aren't gonna be able to afford a lot. I mean, that's the whole point.
that's right. And don't forget about your community resources. There are a lot of churches and just good natured groups who are willing to help patients with transportation. If it's, especially if it's for something that might just be 1 or 2 weeks. There are a lot of great community organizations.
Yeah, good, good. So, but the key is, this is gonna take some planning. It's not pick up the phone and call an ambulance.
That's right. It is going to take some planning. And I think that's one of the hardest things about this. And I think that's also where the concern comes in for the prior auth. What happens if something falls through? What happens if your condition changes? Can they respond quick enough to ensure our patients get the care they need?
So what, Andrea, should we be advising and thinking about for our primary care workforce?
Well, one, I think have to help our patients be prepared and stay informed of rules. That way they know what transportation resources are available to them and the time period that leads up to it that they'll need to be thinking about, "Well, how am I going to get there? And do I need to submit any forms or place any phone calls ahead of time?" For our physicians, as you start to read through some of the OIG cases, our physicians need to make sure that what they're certifying or authorizing is a true statement for the patient. Meaning that if you're certifying that a patient's bedbound, we need to make sure that that patient really is bedbound. We also need to help patients find alternatives. And so, having the great care management teams we have, they have a lot of community resources and they continue to grow that list so that we can offer patients additional resources in their community to assist them. The other option is when you look at Medicare Advantage, a lot of Medicare Advantage and supplemental plans offer free transportation. I believe it's actually one of the top 3 offered kind of in-kind benefits to an MA plan. And so as you're working with your field marketing organization, or better known as kind of an MA broker or someone who's working with you to determine what's the best plan for you. If you know you're going to be needing a lot of transportation, make sure you're asking that question to ensure that you are matched with a plan that gives you the best benefits. I think the last thing is see what's available to get in your home. Especially during COVID, we saw a lot of waivers that allowed for more in-home care. And there are more and more services available in the home. So anything that can be done at home eliminates that need for transportation.
Well, Andrea, I think this is so helpful and really appreciate you bringing this to our attention and all the work that you're doing to help our providers address and cope with this change. So thank you so much for joining us, and I hope you'll come back sometime soon.
Thank you, guys. Always love your podcast and listening in.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.